Helen, we can't hear you. Helen, we can't hear you.
Good morning.
Good morning.
Okay, good morning. I'm sorry, little mishap. Let me just make sure I recorded. Yeah. Good morning. It's the 8th of May, 2020, and we're in the middle of a COVID pandemic, and we are trying to keep everybody informed, and we also have colleagues from Zurich joining us this morning and sharing their knowledge base. First up, the give us a situational update. Let me just quickly, give me a second before, so I can share the screen. Why is this not sharing?
Yes.
Apologies again, I'm just admitting patients at the moment. Where is it? Here. Today we are not as slick as usual because Kevin hasn't got his computer to allow us more people in. Are you all seeing? Somebody unmute themselves and tell me whether you are seeing the screen. Somebody just WhatsApp me or show me on the chat whether you're able to see the screen. Yes, thank you.
Seeing the screen?
Yeah, we can see it, Helen. Thanks.
Okay, good. Stop, everybody.
Thanks.
Unmute everybody.
Okay, good morning, everyone. So just a very quick situational report. We're going to give more time to our guest speakers today. And I'm just quickly going to show one slide on testing and then a new situational report. So testing in South Africa is still PCR based with drive-through facilities in all 3 primary private labs, with some testing capacity starting to show its head right now. So PathCare, for example, has a turnaround time now up to 72 hours. The Empath turnaround time, though, in Cape Town has increased, and we've been getting results sometimes as quick as 6 hours. And Lancet is now also providing increased services through the use of a multiplex PCR. Unfortunately, the NICD is now experiencing significant delays, and we've heard reports of waits of up to a week for results. Our testing is still based on mainly symptomatic people, but obviously some asymptomatics, and the Life Hospital group has up until now supported the screening of all admissions, but not made it mandatory, but that may change. It will change, in fact, from today.
Yeah.
So it is now mandatory.
Everybody mute themselves.
Okay, moving on to the situational report. This slide looks worse every time I show it. So we're now at approaching 4 million cases worldwide. And we've exceeded 250,000 global deaths. But obviously, we are starting to see the number of people who recovered increasing. Right, so looking at South Africa, as of this morning, we have 8,232 cases. We've had 161 deaths, and we have had 3,000 recovered. This is probably the largest jump in a day that we've seen in some time. So this is a quick graph of our number of cases, and the curve, as you can see, just keeps getting steeper and steeper and steeper. Sorry, next slide. So this is a table taken from Worldometer, again showing the number of daily new cases. And what's interesting is they've now added a 7-day moving average line to this, which sort of gives you a better idea without the granularity of day-to-day reporting, which is subject to error and delay. But no matter how you look at this, our number of cases is going up, followed as usual and as predictable by our death rate increasing 2 weeks after the new case rate goes up. Looking at the provincial statistics, the Western Cape is our new epicenter. We've crossed 4,000 cases today, with Gauteng following us probably at close to 2,000 cases by the end of today. Now, what's going on locally in our hospital? We have 11 confirmed positive COVID patients. 3 are in ICU, 2 are intubated, and 1 is receiving oxygen support through non-invasive ventilation. We've got 8 in the general COVID ward, and just out of interest, we admitted the first mother-child pair to the ward yesterday. We have 5 PUIs in our general ward, all on nasal prompt oxygen. And to date, we've had 1 ICU death, which happened early on, a good few weeks ago, and he had severe comorbidities of metastatic carcinoma. And the last thing I want to show is the Ampath lab, which we've been using for the last week, has screened 50 people in that date range. 11 are positive. So we're now screening at a 22% rate through that laboratory. And this represents an increase, significant increase for our hospital. Thanks very much. And with that, I'm going to hand back to Helen.
Okay, thank you very much, Kevin. That just gives you an idea of what we're experiencing. Our numbers are going up, and just with the Ampath, just to let you know that we're using that lab at the moment because the turnaround time is faster, and it's just for our inpatients and our admissions, and it helps with the flow of getting our PUIs into the appropriate wards and into the critical care areas where they need to be, and we want to be safe. And of course, we don't want too long turnaround time with our properly diagnosed or characterized patients. Next up, Friedrich, can you show yourself? Friedrich, there is Friedrich. I'm going to unmute him. You're unmuted.
Yeah.
Friedrich, I'd like you to take over from me. We have Friedrich and Dr. Silvana Rampini joining us today. Thank you so much. I hope you're having sunshine in Zurich. We're having sunshine here, although we're going into autumn. Thank you so much today for sharing your insights and making time available to us. Friedrich, I'm over to you, and I'm going to mute.
Okay, thank you so much, Helen and Kevin, for inviting us again. It has been now, I think, 3 weeks that I gave the presentation about the 2 cases here in Zurich. So this time, our situation has changed a lot. We are at less than 50 cases per day. We were 3 weeks ago, we still had about 1,000 cases per day. So things are getting much better. We are at a steep decline of new infections, which is very good news, which gives us time now to look at the data that we have collected. And today I've invited my colleague, Dr. Silvana Rampini. She's a internal medicine and infectious diseases specialist. We both work in the Department of Medicine here. Silvana is heading the outpatient department of the Department of Medicine and is also the head of staff health. And before I'm handing over to her, I need to share the screen, and you have to then just give me the, yes, it works. Is that?
Yeah, that's fine.
Can you, which screen do you see? Do you see the, I have 2 screens.
Double, yeah.
Do you see the big one or the small one?
Both, Friedrich.
Okay, let me just unplug this one here. All right, is that fine?
Yeah, we can still see both, but it's okay.
Okay.
Great.
There we go.
Is it better?
Yes, perfect,
Yeah.
perfect.
So Silvana's sitting next to me, and I'm handing over to Silvana from, she's talking as the head of medical services for healthcare workers or staff health.
So thank you, Friedrich, for the introduction, and thank you, Helen, for the invitation. Dear colleagues in South Africa, it's a big honor for me to talk to you today about taking care of staff during COVID-19 pandemic at University Hospital of Zurich. So the University Hospital of Zurich is a tertiary care hospital academic center, and we have 850 beds. Here, about 9,000 people are employed, and about these, about 6,000 are healthcare workers working in direct contact with patients. It's difficult to give you an exact number of healthcare workers working in the front line with COVID-19 patients. It's important to know that during our COVID-19 pandemic, for now, we didn't even reach the limits of the first organizational step within the university hospital. So we would have been prepared for 2 more steps when the wave would have been more pronounced. So there was a limited number of healthcare workers directly confronting with the problem of COVID-19 at this time. So what happened is, when the first case was detected in Zurich in end of February, all of a sudden we were confronted with problems concerning healthcare workers. At the first place, these were questions about what are the right protection measures for healthcare workers. And then all of a sudden, healthcare workers contacted us with their own illness. They had acute upper respiratory diseases. This was in February and March, so you can understand that we had also parallel the problem of influenza epidemic. So this was a big amount of questions I will tell you later. And the next step was that healthcare workers feared to have unprotected exposure to COVID-19 patients in the hospital or outside the hospital. After having tested staff for COVID-19, we had also positive tested staff, and we had to treat them in home isolation. So this was a new part of our work. Then the staff with chronic disease and risk factor for severe COVID-19 were seeking for advice how to go on with their working situation, if they should stay at home. This was not only fears from people with chronic disease, but all over the place we were confronted with fears and anxieties of healthcare workers. When serology came available, all of a sudden we had an amount of requests from healthcare workers for performing serologies. And finally now, when the wave is going back and the lockdown is easing up, there are questions coming up concerning the return to work. So let's start with the protection measures. Here I show you the general protection measures we are doing now at the university hospital. But you have to understand that at the very beginning, we didn't have all these measures ready. So this was a stepwise procedure, and only now we know that we should work with these general protection measures. So the staff is carrying surgical masks within the campus. So this is all the staff. It's not depending if you are working with patients or without. This is different in the general community because there is no obligation to wear a surgical mask outside of the hospital. Then healthcare workers which are in contact with patients, they have to wear additionally a plastic glass. And if they perform aerosol producing activities, they have to wear a mask which is of a higher quality, the N95, or in Switzerland it's called FFP2 type of mask. The patients themselves, they wear a surgical mask if they are in contact with healthcare workers or other people inside the hospital and also inside their own bedroom. Hand hygiene is very important. This is not only during COVID-19 a hot topic, but during all the years. We had a big focus on hand hygiene, and we had to refresh these measures. And we installed also over 300 new dispensers for disinfectant during this COVID-19 pandemic within the hospital. Then we are all told to do social distancing, which is limited to 2 meters of proximity. We have a visit ban, so the patients cannot see their relatives, and all patients entering the hospital have to enter this in the main entrances. So the entrances for patients and for the healthcare workers are separated for now. All healthcare workers which are able, they are asked to work in home office. And our ICT service has installed over 2,000 new home office workplaces during this COVID-19 pandemic. And finally, we have an assembly ban of over 5 people within the hospital, which means that we have to cancel more or less all the meetings and conferences. And we are working a lot with these digital versions of meetings. So these were all the general protection measures within the hospital. But then we have the PPEs, which we use in direct contact with COVID-19 patients. Here you see the equipment. You see that they are wearing surgical masks. They wear real goggles, not only the plastic glasses. They wear a gown and gloves with long sleeves. They don't wear any protection of the hair or of the shoes. This is, here you see all the material in front or of a bedroom. So on the door of each bedroom, one can see a plan how to perform. This is very important because all the healthcare workers are trained for doing this. But in the situation itself, it's important that they can repeat each step, and they need support by these signs. So you see that they have to do their disinfection, they have to wear all the protection. They enter into the bedroom, they do another disinfection of the hand with the gloves on. They treat the patient, and the patient itself is wearing a mask. And then when going outside of the room, they put away their gown and gloves inside of the bedroom. They step outside, disinfect again, and put down the goggles and the mask and disinfect again. So this sign is very important to reassure the healthcare worker during his working process. So now all these measures are implemented, but in the very beginning, it looked very different. And we had a lot of questions coming up when the first patient was admitted to the hospital. Here you see the phone calls we had registered after beginning of the COVID-19 wave. This is in March, and here it is now in May. So we realized that there were many questions, and we installed a hotline for staff for counseling them and for medical triage. And you see now here the 13th of May, this was the lockdown in Switzerland. And after the lockdown, there was a very heavy burden of fear and questions of healthcare workers. And now around 80 phone calls a day. Only here, the protection measures, the general protection measures I showed you before were implementing. So the surgical mask, to carry the surgical mask, helped a lot and reduced all of a sudden the phone calls we received from medical staff, which means that some of these were not triggered really by illness, but maybe also by anxiety. So this algorithm shows you how we did the medical triage. It's in German. You do not have to realize what it's written exactly, but I will show you through. On the right side, we have the situation that the healthcare worker calls us with his own illness. So we ask in a structured way all the symptoms concerning their illness, which were acute respiratory syndromes. We ask about cough, sneezing, about loss of taste, about dyspnea, fever, aches, or reduced general condition. It was very easy if the symptoms were very pronounced. So if there was a severe illness like fever with dyspnea and coughing, so we were very sure that we need to do a testing. And if this was the case, we sent them to our testing unit for a nasopharyngeal swab and PCR. It was much more difficult when the symptoms were very soft or low. We had many people only with a little bit of throat ache or a little running nose. And we realized during the pandemic that if we test all of these the first day of their illness, we cannot find any positive results. So we started to advise them to protect themselves very well and in particular also at home. They could go on with working with the protection measures. And if the symptoms get worse after 48 or even better 72 hours, we then ask them to go for testing. So this is our algorithm for the healthcare workers with an illness. And on the left side, you see the other situation. These are healthcare workers who tell us that they had a contact with a patient or maybe a relative with COVID-19. So what we did then, we looked if they had a real relevant contact to these COVID-19 patients. And the contact is only seen as relevant if it took place without the adequate protection measures 15 minutes of contact, more than 50 minutes of contact, lower than 2 meters of distance, or a real direct contact as in nurse, as the nurse, care of the nurse, or a direct contact in sharing the household. So if these criteria were fulfilled, we were asking them again if they have symptoms. We did not test the healthcare workers without symptoms. Only if they realized to have symptoms during their 14 days of quarantine, then we performed the nasopharyngeal swab. So you have to understand that the quarantine was a quarantine at home, but they were allowed to come to work and performing all the protection measures. So it was not a quarantine which tells them to stay at home for 14 days. So now I would like to show you our results of the SARS-CoV-2 nasopharyngeal swabs in employees since the end of February. We tested 747 symptomatic employees. We found 53 positive, 53 positive employees. This is about 7%, sorry. 34 were females, or the most part were female. And the mean age is 41 years old. We followed all of these 53 healthcare workers during their home isolation. The home isolation is at least a minimum of 10 days since symptoms onset, and they could come back to work after 58 hours of symptom-free period. During this follow-up, we had to hospitalize only one person. It was a 63 years old male. But then he could be discharged without a severe disease. He did not experience a severe disease. He did not have to go on ICU unit. At the moment, we have 50 of the 53 employees de-isolated, and they returned to work. The other 3 are all, for now, are within the 10 days of follow-up period. So we looked, what are the infectious sources of these infections among employees? And we found that most of them were community transmissions. 15 had contacts with sick employees. And 18 of them, 18 infections, we could not really understand where the transmission took place. So they had no known contact to a COVID-19 positive person in the hospital or outside the hospital. So as I told you, we did contact tracing with all these 53 employees as index. We had one outbreak among 11 employees which were working in an open plan office. And we had 4 healthcare workers who had unprotected contact to one other healthcare worker within the hospital. But all these transmission within the hospital took place prior to the implementation of the general protection measures. So prior to the wearing the surgical mask. This is very important for us, that after this, we could not see any transmissions from employees to other employees or from patients to employees. We followed also 18 patients which were diagnosed with COVID-19 during their stay in a hospital. And so these were the index of 18 contact tracings. One example of this contact tracing, it was a patient on ICU. He was tested positive after 7 days of his stay in the ICU. And the 56 healthcare workers were exposed to these patients. But here you have to understand that the exposure was that they did not wear at that moment of the exposure the higher measures for aerosol for aerosol building procedures. All of these healthcare workers turned out to be negative. So we had no transmission of COVID-19 from patient to any staff. Outside the hospital, the contact tracing is performed by our local health authorities, which helps us very much to focus on our work inside the hospital. So now I would like to show you another problem. These are the requests from the staff with high-risk conditions. As background, it's important to know that the Swiss federal government has released a decree which tells that the employer is responsible for the safety and the safe workplace of employees with high-risk conditions. So at the moment that this was known with this decree, we had a lot of questions about workplace situations. We decided then that we have to counsel these staff members individually. We did this stepwise. First of all, we were looking at their underlying medical condition, and if these are high-risk conditions for severe COVID-19, according to our recommendation of the Swiss Societies of Cardiology, Pneumology, Rheumatology, Neurology, Oncology, and Endocrinology, all of these had give recommendations which are the high-risk condition. And if these conditions were present, we explored the workplace situation. If on the workplace they have contact with confirmed COVID-19 patients, or contact with probable COVID-19 patients, or if they have no patient contact. And knowing this, we then also looked if the travel to work could be a major problem, because as we did not have a general recommendation for example, wearing surgical mask in the community, and also in public transportation, this sometimes was the biggest problem for acquiring COVID-19. After evaluating these points, we then wrote a certificate which could have these types of outcome. So maybe there was no high-risk condition and the general protection measures were adequate, or there were higher risk than the general population. And in this case, we told that this person does not have any direct contact to COVID-19 or probable COVID-19 patients. Or if there was a really high-risk condition, we told that the staff has to have home office work. if this was not possible to implement, we had to release from work employees, but this was very, very seldom the case. So in the end, we for now have counseled more than 100 staff members, and we wrote a certificate for more than 50 staff members, and only 2 had to be released completely from work. So besides the staff with severe healthcare conditions, that we have also all the others which are in good health, but they suffer from stress with this corona pandemic. So we installed a corona stress hotline in collaboration with the HR, pastoral care, quality management, and psychiatrist. And you see that we had many calls in the beginning, the first months per day, seeking for advice, and we had now less calls while the wave is slowing down. So finally, I want to tell you about serology. When the serology was available, we had a lot of questions about how we should test and who should be tested. We decided to look at 110 of our already known staff members which had been tested with PCR in the last weeks. And we looked at staff members who had a symptom which began at least 14 days ago. We have 2 tests, one commercially available test and one in-house test for serology. You see that this were 21 patients which were ill and PCR positive. We had 71 staff members which were ill and PCR negative, and we had 18 which were in good health and PCR negative. These were in a contact tracing. And as you can see, the ill people with PCR positive, not all of them had a positive serology. Only 16 of the 21 were tested positive with this type of test. With the in-house Luminex-based assay, we found 19 positive. And in the sick but PCR negative, we found more patients with a positive serology as in this test. But also in the group where there was no illness, we had positive serologies in this commercial test and none in this in-house test. So if we try to define a sensitivity and specificity, and we take the PCR as the gold standard, as we have no other gold standard for the moment, we found that this test had a sensitivity about 90% and this about 75%. The specificity were comparable, and you see that the positive predicted value was very low. So with this data, we then decided together with the infectious disease unit that at the moment we see no profit of doing serologies in staff, because this test only confirms our positive PCR tests, and it does not help and has no consequences for the staff members. So now I want to conclude and give you some take-home messages. So we are convinced that the general protection measures are pivotal and they are effective. We see that PPE protects healthcare workers during COVID-19 pandemic. We realize that there is a very high level of anxiety among staff, and our hotlines were extensively used, and without these we wouldn't have been able to manage the problems of healthcare workers. It's important to have a clear guidance on the triage to test, and also to contact tracing within the hospital. And for the certificates, it's important to assess the chronic disease, which is underlying, and the workplace. And finally, we saw that our in-house Luminex assay conferred at RT-PCR's result of nasopharyngeal swabs, but it does not help so much or has consequences for healthcare workers.
Thank you so very much.
Thank you.
Sorry, I'm interrupting. Go on, go on.
Okay, so I think, Silvana, thank you very much for this talk. And I think it's very reassuring to see that the general protection measures in the hospital actually stops transmission, intra-hospital transmission. And with this comment and this beautiful picture from the Matterhorn with the South African flag, which is currently displayed every evening, you have another country flag projected on the Matterhorn. I give back to Helen and Kevin.
Can I ask a question? Does the hospital use an app?
Does the hospital use an app is the question? No, we don't use an app for the moment.
Are you planning to have one so that the tracing might be easier?
We have no app for the moment. Also in Switzerland, the ETH is doing their own app for contact tracing outside in the community, but it's not released yet. So we don't plan it for the moment.
Helen, we can't hear you.
Sorry. Please, no one asks a direct question. It's going to be chaos if everybody unmutes themselves and then starts talking. Please, we have to just follow and toe in line here. Just to circle back, Silvana, thank you so much. We still have Anthony Levy in the background waiting for us to share his x-rays. I just want to say that we have implemented exactly the same strategy in our hospital right at the start of lockdown. And within 2 weeks, within a week or two, we adopted universal masking, and we have implemented the same IPC measures, and according also risk-based, and also our administrative controls, environmental controls, and everything is in place. So very similar to you. And also what I find so, for me, reassuring, that these safe and simple IPC measures are bearing fruit, so it is not over the top. We are not wearing hazmat suits, and you do not see healthcare worker acquisition of disease from patients.
Yes.
And what is showing also in other European centers, and what we're seeing, is actually our patients are sitting ducks from us. Okay, so if we don't wear masks, we're giving our vulnerable patients to it. So that's why I'm saying it, and that's why your data is brilliant and so important for everyone to hear now, because we are at the start, and for us this is reassuring to get rid of the panic and the fear.
Yeah.
Just in terms of a hotline, unofficially, Kevin and I have been the hotline for the last
Yes, I know.
and it's not recognized, you know, that we field about 100 calls a day informally, including WhatsApps. And the next question, there was a question about why are we swabbing our patients or healthcare workers at the moment. So at the moment, we have 2 patients that have been long stay, and they were routinely screened because they were going to go to another facility, and the one patient developed a new cough. We were alerted to it and detected positive in hospitals. So this is an infection acquired in the hospital.
Mm-hmm.
Now, for everybody on the audience, this is a situation where we need to look who is exposing the patient. So we're doing an outbreak investigation. So that is different to screening symptomatic healthcare workers. So I just had to put it out there because of that question, and why are we screening healthcare workers suddenly? And I'm sure you did the same when you found somebody where you thought this was a healthcare worker acquired an infection acquired from your hospital. So that just everybody in this audience understands this. So our patients that we just want to do elective surgery on, etc., will be maybe getting the infection from us, you know. And I like the way you said you tested your mildly symptomatic patients are healthcare workers as well, because they're the ones transmitting it. Do you want to just comment quickly on that? With whether you've had patients where you know they got the infection from healthcare workers?
We don't have seen any patients with acquiring COVID-19 within the hospital. We did do some outbreak or search, but we could not find a real transmission on patients. Yeah.
Okay, because yeah, Friedrich, have you come across it? Because our problem, our vulnerability is transport, and you showed it again. You know, our nurses have ride shares, lift shares in cars. This is where we're seeing our healthcare worker infections, and you know, everybody wants really. You know, and I find it so reassuring in a first world setting, you use minimal PPE, you use it rationally, and you do not see healthcare worker infections. And for me, it's just so great that you showed this, and the way you stratified your occupational health service as well. Kevin, do you want to ask a question still?
No, I think that covers it. The main thing from us was these inpatient diagnoses. Interesting, we're having a different experience from you.
Yeah. So our patients are vulnerable, and I will think twice whether I would like to have my hip replaced at this time in the COVID pandemic. I would not opt for any intervention at this stage, because you're going to be at risk in hospital despite all our best efforts. Okay, so next up is Anthony Levy. I'm going to show Anthony. Can you please unmute yourself and also show your face?
We will say goodbye from Switzerland. We need to go to the X-ray meeting. Enjoy your X-rays.
Thank you so much, Friedrich, and stay safe in Silvana. I'll send you an email. Thank you so much. Okay.
Thank you.
Bye bye.
Bye.
And I hope you don't have a problem. Bye.
No worries.
Cheers. Bye.
Bye. Anthony?
Yeah.
Can you share your screen for us? Thank you. You're an expert already. I'm going to mute my audio. It's you.
Okay, so everyone can see that. Guys, I've got 10 minutes, but I'm going to, whatever we don't get through, I'm going to speak first next week, according to Helen. So I spoke very briefly beginning of this week about the problem with our PCR testing, that the pickup rate is only 60 or 70%. We've got an added disadvantage that we don't have rapid testing available in our casualty units or in the hospital, and we're seeing now that the PCR takes hours in certain centres, up to even days. And in Cape Town, we're at a major disadvantage because a lot of the tests are sent to Johannesburg. So for the purpose of this talk, we talk about chest X-ray and CT. I think most of us have already seen, and we've heard of ground glass opacification. It's normally bilateral, it's normally posterior, and it's normally multi-lobar involvement, and it's peripheral. And there's more consolidation towards the progressive and the peak stages of the disease. And as mentioned earlier by Silvana, in the early stages, it's very easy to get a negative PCR result, but it's also very easy to get a negative chest X-ray result. So never be confused if it's in the early stages of disease. If your patient has a normal study, especially a chest X-ray, we know that CT is way more sensitive. If you've got a normal chest X-ray in the peak stage, it's probably very unlikely to be COVID disease. So in the early stages, CT is more sensitive. In the later stages, to pick up a consolidation and the multifocal opacities, chest X-ray has got more of a role. So just the definition, there are lots of specialists and there are also lots of GPs in the audience, but when we talk about ground glass opacities, we talk about hazy increased opacities, and they're very poorly defined. Whereas when you talk about consolidation, there's a homogeneous increase, and you actually can't see the vessels and the airway walls. So the ground glass opacities can be very difficult to pick up in chest X-rays, especially when we're doing mobile examinations compared to formal X-rays in our department. And when patients come in, we actually are doing mobile examinations with PPs with suspected PUIs, but it's not as sensitive as PA X-ray. So this is an example. I showed it this week. Probably about 3 months ago, most of us would have ignored this, but now with COVID, we COVIDized. That's a definite ground glass opacity. And as it progresses, a few days later, you can see the bilateral changes. This is another patient that presented with chronic renal failure. You can see these bilateral changes. One would even suspect, well, maybe this is a pulmonary edema, fluid overload, but the dead giveaway is peripheral, and we're more attuned to patients who have comorbid disease. Any patient who has renal failure, renal impairment, diabetes, hypertension, comorbidities, we've got to have a very high rate of suspicion. This is what the patient looked like on the 30th of April and 17th of May. So in retrospect, maybe early changes, as we mentioned, the earlier disease, the harder it is to actually pick up the abnormalities. This is probably our first case that we never reported as COVID because we weren't thinking of COVID at the time and the patient didn't meet the case definition. 19 of February, already 30-year-old female, and these are classic peripheral ground glass changes with areas of confluence, early air bronchograms. And this is what the coronal reconstructions look like. And this patient was well. This is the X-ray on the 11th of March. If we were to do a CT chest on her, we might see parenchymal fibrous bands, and there's a lot of literature coming out now saying that what we're going to find after this crisis is there are going to be lots of patients who are respiratory cripples because they get a lot of scarring post-infection. So there's so much information that's out there, and it's changing basically weekly that it's very hard to actually keep up with it. But coming back to very subtle ground glass changes, a CT was performed, and one can actually see those ground glass opacity so spectacular. This was not a mobile X-ray, so a mobile X-ray would have been even less sensitive. So don't be fooled if you've got a normal chest X-ray that for certain selected cases, and I'd say definitely comorbid patients entering our facility, we might want to be a bit more aggressive with our imaging going on to CT, uncontrasted high-res CT, especially considering that we've got such a backlog with our PCR testing. We don't have serology available. This is just a patient traveling in China. I'm just showing you the different temporal changes. See these classic ground glass changes in the lower lobe. 3 days later, they become progressive, and it's very useful for looking at temporal progression of disease. And obviously, one cannot just go and do CTs in everyone, we need proper clinical guidelines. So this is a comparison of a study published on the 7th of February. Just to point out a few things, consolidation is common, but that's in the later stage of the disease, the time of onset, probably more than 3 days. The ground glass changes are the majority, and it's got to be peripheral. It can be central also, but that's also with later stages of disease. If a patient comes in and their symptoms only started yesterday, and they've got central changes as well as peripheral, it's probably unlikely that it's COVID disease, where if it's more peripheral, it can be a clue, whereas if it's a week, 10 days down the line and the central changes also, it's compatible. So one has to be attuned, and we definitely need corroborative, better clinical information on our request forms that unfortunately casualty is not great at, but specialists and GPs are. So can CT help distinguish mild versus severe disease? I think this is a very pertinent question in our setting, and it can. So there was a retrospective study, 70 patients, came out of China, and they basically divided the patients into group 1 who had mild disease clinically as opposed to more severe disease. And they try to classify the CT changes into number of segments involved, the distribution of the opacities, size of lung opacities, and type of lung opacities. And it seems very busy, but I'm just repeating what ground glass changes are, just so everyone's got it in their head again. But what they did find is that there's often multilobar involvement, and depending on whether or not the patient is how symptomatic they are, those changes did seem to correlate slightly. There was a lot of overlap also, and what this has led to is that there's actually a CT grading now of changes on the CT scan that one can put into an algorithm, giving you a predictive value of whether or not this patient has disease compatible or not. And this has come out in the last month, so it is quite fascinating. I'm just going to skip a lot just to get you further informed. You can imagine how subtle these changes are. It would be impossible to see on a chest X-ray. The basal changes one would see, but if you're only presented with these two changes, which would be enough to suspect COVID in our population, especially since we probably further in the pandemic than the rest of the country, there's going to be more prevalence in asymptomatic patients of these findings than a month ago. And that's also key. You're going to have more changes on a routine CT scan for patients that we do imaging as opposed to normal chest X-rays that we did a month ago. This is the example of crazy paving with this interstitial thickening in between the ground glass changes. So it's all in the continuum of ground glass changes. This is a patient who, if we saw that in a patient 3 months ago, we'd just say there's atelectasis and some non-specific ground glass changes. The problem is these non-specific changes now can be COVID, but they can also be something else. So if every patient had classic COVID changes, it would be easy and CT would be the gold standard. And if every patient that was negative had no changes on CT, we'd have a very high specificity. But unfortunately, towards the middle to end stage of the disease, that's what we're seeing, these confluent opacities, ground glass changes with interstitial thickening. But I think the take message on this image is you can imagine how months down the line, we're going to be finding patients with tons of scarring that say, well, they're asymptomatic and they haven't been sick before. And I think the pulmonologists are really busier post-COVID than they are now. I found this incredibly interesting. This was the Japanese basically scanned all patients who were asymptomatic off the Diamond Princess, and they basically showed that of 104 cases, these are only the patients that were admitted for quarantine, the Japanese. 76 patients were asymptomatic, and 54% had mnemonic changes in CT. And that is quite remarkable that in a setting where you've got a high percentage of patients that have COVID, your asymptomatic screening using chest CT is going to be way more sensitive. So in the Limpopo province, I think if you scanned 100 patients that were asymptomatic with H1CT, you get a 0 pickup rate. If we got patients from Mitchell's Plain now and Khayelitsha, our pickup rate in asymptomatic patients will be a lot higher. So this becomes more pertinent further in the disease that one is. And the asymptomatic cases also showed milder CT severity score than symptomatic cases. So that's reassuring. But the problem is, aren't enough trials to compare patients who have multiple comorbidities. So it raises a few questions. The role of CT in asymptomatic patients or patients with mild symptoms, and combined use of antigen antibody testing that we don't have. Now, every country, every city has their own algorithms, and it basically depends on what resources we have available. Our major problem at the moment compared to other countries is the significant delay in PCR testing results. I think CTPA, your patients have chest pain. Remember, up to 30% have central pulmonary emboli. We try to drum it into casualty officers around the peninsula that you don't have to have a home and school to have a PE. So when you ask the casualty officers, well, does the patient have chest pain? They go, yes, but they don't have a clinical DVT in their card. So I think that's something we need to get out, that even though they've got chest pain and you've got no signs of the classic DVT, take pulmonary embolus and possibly do a CT. Also, what a lot of centers are doing overseas is they're adding on CT chests to routine CT abdominal pelvis examinations. If a patient comes in with question mark appendicitis.
Anthony, stop. Sorry, somebody has a child in the background who's making a record.
No, it's actually mine. Let me go and remove him quickly. Sorry. Ariel. Sorry, it's my 3-year-old.
We're not, yeah, we just wanted to
No,
get
he's being
over an hour. We're over an hour. Okay, cool. We don't want the baby's COVID insights, just yours.
No, he's been removed. He was up the whole night looking at CTs with me anyway, being on call.
Oh, goodness.
Anyway, so,
crazy craving.
The other thing, I attended a webinar from the University of Toronto yesterday. It was a 3-hour one. It was very interesting, but what was fascinating was that every center has their own protocol, depending on what availability that they have. And there was a chap speaking from Pamplona in Spain, and he says every single patient pre-surgery now gets a CT as well as a PCR. There were some units in the States that laughed at it, and when you dug into it and you asked them, they said, well, we've got rapid serology testing, so we need a result within 30 minutes. So we can do 4 tests on a patient before they have surgery. So we have to play up to our resources and what we have available. I've been speaking to a few surgeons, and we were thinking of maybe getting a trial running on whether or not there is actually any use of adding on a CT instead of a chest X-ray onto certain patients. Because what we don't want is having patients, asymptomatic patients, come into our hospitals and infecting well people, infecting doctors, infecting healthcare workers who potentially will infect other patients. So this is something that's coming out from literature, but it's too short in the pandemic to have any randomized control trials. I read this morning, and it's actually very distressing. So the Western Cape Department of Health has been forced to turn to the private sector because it's taking days for results to come available. So it's a real issue in the Western Cape where we've got the highest numbers, that it's taking a long time to get results out there.
Okay.
So,
thank you so much, Anthony. Just there's a note about the laboratory testing. We know that there's a problem with the testing, and that's why with the asymptomatic tests that we also stress our assistance even more, because of the fear that everybody has, and that's why the talk earlier was so very, very important. That
Helen, can you hear me? Hi, Helen, you've broken up. I'm not sure if everyone...
Community testing has put the NHLS under huge pressure, and that's why there's such a delay. And I think from the ID societies, we're asking now the Western Cape government to back down with the community testing and actually focus more on the healthcare facilities and do the testing in those settings. Kevin, do you have a question? I think Kevin had a question.
So I think I was very interested in the post-infectious lung scarring, and just wondering, if you're seeing CTs that are really already showing quite severe disease, would we be able to predict that there might be severe scarring from those scans? And would that be of any use in our resource limitations? Would we ventilate if we knew someone was going to be a respiratory cripple?
Well, what they are saying is there was an article that came out this week, and it said that they've already started saying what should patients get routine scanning post COVID disease, and they're actually recommending scanning 6 weeks afterwards and 3 months after to see what the changes are. But there hasn't been enough retrospective studies to see whether or not there's actually those kind of changes. Guys, I've actually only finished half my talk. I'd really appreciate to get some time next week, because there's even more important information that's coming out there.
Yes, and you will. Thank
Can I speak first, Helen?
Coming, we'll be very nice to you.
And I'll speak first.
Yeah. So sorry that we're doing this to everyone. We're over time, but I thought just as a priority, I needed to get this message out that we are putting our patients at risk. And definitely, Anthony, we're going to give Kevin 2 minutes and you can have more time. Thank you so much.
Oh, that's
perhaps
fantastic.
if we get another radiologist on as well at the same time. Then next, so you will have another slot on Tuesday when we have our next meeting. I would like to get feedback from the group. If you find these meetings valuable or a waste of time, let us know. It is a way for us also to communicate to the other doctors at this facility to share what is currently going on, and that you have a little bit of a feel of what is happening in the hospital, and we can share that with you in this format. And that's why Kevin is doing the regular situational updates, that you don't feel left out because you don't get to go into the COVID wards. Certainly getting busier, and we're seeing more patients. And as I mentioned earlier, we have 2 patients where we're currently investigating whether or not the transmission occurred from a healthcare worker to a patient in hospital. So there's no definitive answer yet. We don't know where the transmission occurred, so you can't quote me in the media or sensationalize it, because I will deny everything. Then there were 2 questions, whether these recordings will be available. Yes, there will be. I will let you know on the WhatsApp group where there would be accessible. And then with respect to CPD points, there was a question in that regard. I will look into it, that we kind of get your names even retrospectively, and you can just mention you attended this meeting or webinar, or whatever. On a webinar forum, we might be able to collect your HPCSA numbers and do it more professionally. So that's it from us today. I was told by somebody else to end the meeting by saying it's 9 minutes past 9 on Friday morning, the 8th of May at Vincent Pallotti. Goodbye.